All right, I hope everyone can see my screen. It's a pleasure to be with you all today and I guess meet you in this virtual format. So I am going to start here. So we're going to talk about erectile dysfunction and urinary incontinence here today. Oops. So this is a little bit about me. I currently work at McKeever Clinic in Jacksonville, Florida. I was born and raised in Ohio. Did my medical school training at Northeast Ohio Medical University, followed by residency at Cleveland Clinic. And then I did a one-year fellowship training in andrology, men's health, erectile dysfunction, that type of thing at the University of Virginia as well. So let's talk a little bit about kind of learning about erectile dysfunction. Why does it happen? So what is erectile dysfunction? It's characterized as the inability to achieve or maintain an erection firm enough to have sexual intercourse. In terms of how common it is, actually about 1 in 5 American men 20 years or older will actually experience ED in their lifetime, with more than half of men over 40 expressing some degree of erectile dysfunction, and it affects approximately 39 million American men. So pretty common, more common than most people think. This is just kind of a diagram demonstrating the vasculature of the penis, both in the non-erect state or the flaccid state and the erect state. As you can see in the erect state, there's kind of engorgement of blood vessels that give you a physiologic erection. So ED can have a broad number of impacts. So there's a lot of comorbidities that can cause ED. And this is a diagram just demonstrating the different types. So 40% of erectile dysfunction will be due to vascular causes, 30% is due to diabetes, with 15% being due to medication side effects and some others as well. So let's talk about erectile dysfunction and diabetes. This is something I see very commonly, patients with diabetes coming in with erectile dysfunction, kind of trying to make the connection. So according to the 2015 census data, 15.3 million men in the US have diabetes. And diabetes and erectile dysfunction have a very intimate relationship, both in terms of how it's caused and treatment. So patients with diabetes and ED have been shown to be less responsive to oral treatments for their erectile dysfunction. Also, patients in men with diabetes, ED is usually more severe, and that severity will be associated with a decreased quality of life. And then in some patients, ED can actually be the presenting symptom of diabetes. So I'll see a man who hasn't seen a doctor in years, but obviously having issues with erections, and he comes and sees me, and then we end up talking, and I recommend him see a primary care doctor, and he ends up getting a diagnosis of diabetes. So that will be the way he may be diagnosed. So we talk about ED occurring due to diabetes. So ED pills do require stimulation of the nerves and healthy blood vessels. With diabetes, that circulating blood sugar can damage the nerves and blood vessels, and therefore result in less effectiveness of oral pills. Some factors that may increase erectile dysfunction in men with diabetes. So, a lot of men have diabetes, but also typically older. So that will worsen their ED severity. How long they've had diabetes, also having some kind of vascular disease as well, being on diuretics or having heart disease. And this is tying into, heart disease and how that's related to erectile dysfunction. So there is also another very close link between having heart disease and erectile dysfunction. Symptoms of heart disease may actually develop within 2 to 3 years of ED. And this is another patient population where a guy comes and sees me, issues with erections, has been the doctor, and that actually may be a sign that there may be an issue with his heart that he may not know about. And that kind of opens the door to him realizing that. In terms of just looking at how it can be impacted on a blood vessel level, at 50% blockage, the penile artery may cause symptoms of erectile dysfunction. And this is kind of showing you how big the different vessels in your body are, just kind of showing you how small that penile artery is. So, any kind of blockage will lead to a global impact in their erectile dysfunction. So how can a men in this type of population, or men not having heart disease, reduce their risk of getting to that level? Definitely lifestyle. So diet, healthy diet, increased exercise and physical activity, weight loss. Patients who are smokers, quitting smoking can improve erectile function, and also reducing stress. So what's the relationship between erectile dysfunction and low testosterone? Because this is another place where we see it. So low testosterone occurs when a man's body produces less testosterone than normal. And as men get older, typically when they cross the age of 40, 45, physiologic levels of testosterone do decrease over time, but it can be different from man to man. So it is more, low testosterone can be more commonly seen with other things that can increase its risk, including obesity, diabetes, high blood pressure, high cholesterol, prostate disease, or asthma or COPD. And it's fairly common, actually approximately 4 in 10 men over the age of 45 may have low testosterone. With every 10-year increase in age, the risk of low T increases by 17%, as I kind of said. So there are treatment options for low testosterone. So again, this is a guy seeing me for ED. We find out he has low testosterone, we confirm it. Some different methods to treat low testosterone include gels, patches, oral medications, or injection, both intramuscular and below the skin. There's also another close relationship between erectile dysfunction and prostate cancer treatment. This is a very common patient population of patients had prostate cancer. They had it treated in some form and then, come see me for erectile dysfunction. So how does that happen? Well, if a patient has prostate cancer and say they had surgery to remove the prostate to treat the cancer, there's an intricate network of nerves that basically align themselves and attach to the prostate on both sides, and those are called the neurovascular bundles. And obviously you're trying to remove the prostate to remove the cancer, but sometimes some of these nerves can get injured, and those nerves are important in erectile function, therefore leading to erectile dysfunction issues following their surgery. After the prostate's removed, as you see on the right, the bladder is then reattached to the urethral sphincter to restore the ability to urinate, and we'll be talking about that later in the presentation in terms of why that's important for continence or voiding. So how common is sexual dysfunction after prostate cancer treatment? Well, after surgery for radical prostatectomy, when they remove the prostate, erectile dysfunction can affect 25 to 75% of men, so a pretty big range. And despite techniques, there's surgical techniques to try to preserve nerves, called nerve-sparing robotic surgery to remove the prostate. Erectile dysfunction may persist a year or more after surgery, despite our best efforts. And sexual dysfunction even after radiation, so even if they don't get surgery and they undergo radiation, that can also affect up to 50% of men. Typically, erectile dysfunction after surgery, we'll see it a little bit sooner after surgery, after their treatment. Whereas radiation, they get their treatments, we may not see it right away, but that erectile dysfunction can kind of develop later in time. So let's talk about erectile dysfunction, Peyronie's disease. So Peyronie's disease is a fibrous scar tissue in the penis, and that essentially will demonstrate itself as a penile curvature. Typically, the penis will curve in the area of wherever that scar tissue or plaque is. There can be numerous complications, treatment options with this as well. There are alternative treatment options that are investigational as well for treatment of erectile dysfunction. These include shockwave lithotripsy for the penis, stem cell therapy, injections, and also platelet-rich plasma injections. These are all actively being studied and currently considered investigational based on the American Urologic Association guidelines. So these are kind of the main treatment options I talk to patients about when they're presenting with erectile dysfunctions. I always talk to patients in terms of, okay, well, we start least invasive and kind of work their way up, but ultimately it's up to the patient and kind of their situation. So we start with oral medications. A lot of you guys are familiar with these, Cialis, Viagra, then move toward penile injections, Trimix, Bimix, Edex. Some of you may have heard of these. There are also vacuum erection devices, urethral suppositories, and penile implants. And we'll be talking about each of these in more detail as we move along. So let's talk about the oral medications. How do they work? So these block an important enzyme that removes blood vessels basically prevents blood vessels from constricting to keep the blood vessels engorged within the penis to maintain an erect state. They are typically effective depending on the patient and the severity of the erectile dysfunction. Just kind of depends where they're at in their spectrum, their history. Some side effects can include headache, congestion, facial flushing, and cautions. These can also exacerbate heart disease if present. So I always talk to patients and ask them if they've had any heart issues or cardiac events in the last 4 months, or if they're taking nitroglycerin, because that can result in dangerous decrease in blood pressure. So we like to monitor that. So injection therapy is fairly effective as well. It's upwards of 80 to 90%. However, 40% of men actually end up discontinuing or stop doing it, mainly because they don't like the idea of sticking needles in their penis repeatedly. Some of the side effects that can happen is if they repeatedly inject in the same side. So I tell patients always alternate sides. So if you injected yourself on the right side of your penis, inject yourself on the left, because if you inject yourself on one side repeatedly, that can form scar tissue and then result in Peyronie's disease. And those are, again, are some of the reasons for discontinuation. Vacuum erection devices. So this is basically a device patients obtain. It creates a seal in the penis and traps blood flow in the penis. This can be via either a vacuum erection or penile ring. So it can be effective depending on the right patient as well, but some of the side effects include bruising, penile pain, and just kind of ease of use. Each vacuum erection device is a little bit different. So some patients may find it doesn't get a good seal and can be cumbersome just depending on the device and the patient. And urethral suppositories, these are actually pellets that are inserted via an applicator through the urethra, the penis you pee out of, and placed within there. And it basically works by stimulating blood flow to the penis. We don't actually use it very commonly, just because when we talk about side effects, it's not very comfortable to place something within the urethra or the penis, and the most common side effect is actually pain, just because that's also the tube you urinate out of. So those are the biggest reasons for discontinuation. So a penile implant. So penile implant surgery is a surgery that we perform. So we place 2 cylinders within the penis, a pump within the scrotum, and a reservoir balloon. Sometimes I just describe that to patients, that holds fluid, and they're all connected in a system. And how it works is essentially, these tubes within the penis, the cylinders, will be empty. When you want an erection, you have the pump within the scrotum, and you basically pump it, and that moves the fluid from the reservoir into the cylinders to fill them up and then create an erect state. It's great in the sense of it's cosmetically, the 3-piece device, as you can see here, cosmetically, resembles the appearance of a normal erection very well. It's all concealed within the body. There's pretty great satisfaction rates. I think upwards of 98% of patients who've gone through it have been happy or pleased or would recommend it to a friend. The biggest side effects or complications are pain and discomfort during healing, just because there can be some swelling that while the tissue is healing, and infection. Just because it's an implant, a foreign object we're putting in the body, we always worry about getting infected. So that's the other potential complication. The other potential is that it may stop working. It's a device after all. But as you can see on the screen, at 7 years, 94% have been shown to still work properly. So the 3-piece penile implant is the most implanted, and the Boston Scientific implant in particular is the only one that has a patented antibiotic coating basically on the device, because like we said, one of the complications is infection. So that's one of the nice things about the Boston Scientifics is that it has this proprietary antibiotic coating to help prevent infection. They've actually been in clinical use for over 45 years, and over 500,000 men have received a penile implant. So here we have a video on how it works. I'll show you all. So as you can see, everything is concealed, and when a patient wants an erection, they squeeze that pump, and that moves the fluid from the reservoir we place in the abdomen and the cylinders to basically make them full. to create an erect state. When a patient no longer wants the erection, there's a button on the pump that they press, and that moves the fluid back into the reservoir. It's nice because some of these other treatments for ED, you have to take them a certain time period prior to intercourse. With the penile implant, it's an on-demand erection, and typically, orgasm and sensation or feeling is intact. So, and then here is another video, unless it's the same one. I think it may be. So let's talk about the procedure itself, or what to expect. This is typically performed as an outpatient procedure under anesthesia, so you will be asleep. There will be a small incision either under the penis on the scrotum or above the penis on the pubic bone. Typically, I tell patients take a couple days to return to their normal routine, light activity, and we want everything to heal up nicely. So while everything is healing, we wait, and then we bring patients back about 4 to 6 weeks after placing the implant to teach them how to start using it for intercourse when it's safe and we know everything is healed properly. So cost and coverage is typically a question I get a lot of patients asking. So insurance coverage for ED treatment will vary. It can vary based on insurance. It can vary based on state and location. And continence treatment is typically covered by insurance. Coverage for implants may be available under Medicare and Medicare Advantage, but there can be some resources. So, I always tell patients, let's try to exhaust every option. We're looking at cost. So one thing, talk to the specialist. We can work with the insurance and manufacturer, verify the benefits, and even helping to resolve coverage exclusions and asking about financial assistance options. So, I work with Boston Scientific to see if there are resources we can use to help patients in their individual cases to see if there's a way to get it covered. So what are the benefits? Again, 97% patient satisfaction, 98% partner satisfaction with a 3-piece implant. It's clinically proven to reduce risk of infection with their patented antibiotic coating. It's affordable in the sense that it will be typically covered by insurance and or Medicare in proper circumstances. It's long lasting, durable, 89% still in use after 10 years, and it's natural. It's designed to maintain a natural appearance in the rectum flaccid state and doesn't interfere with ejaculation or orgasm, and spontaneous. Again, this is nice because it's not like Viagra or Cialis where you have to take it, hour, 2 hours prior to intercourse, empty stomach. That kind of gets rid of the spontaneity between your, sexual interaction with your partner. So it's nice that it's a non-demand erection. When you're ready, you can pump it up and be ready to go. So as a surgical procedure, there are risks. Not all patients are candidates. So some of the things I always talk about with patients. So one, so say we place an implant, we have to take it out for whatever reason. If we take it out and don't put another one back in, it would make natural or spontaneous erections as well as any other interventional treatment options impossible, because we're essentially removing the space where all those blood vessels are to place those cylinders. So those blood vessels would no longer be intact. The risk is always a mechanical failure. Like I said, it's an implant. And if that does happen, I have patients where we remove them and we just place a new one in. Pain, again, that's typically just seen immediately after surgery as everything's kind of healing. And that pain is, usually due to some swelling that occurs that will heal over time. When we talk about infection, particular populations that might be at risk are men with diabetes, men with history of spinal cord injuries or open sores. In the general population, though, there is only about a 1.2 to 2.5 risk of infection with inflatable penile implants. So to summarize, it is a common issue. Like we said, we highlighted more common than maybe some of you may have thought. There are a variety of treatment options available. And penile implants could offer a long-lasting and satisfactory solution in the right patients. And edcure.org is a website you can go to learn more about these things. So now we're going to pivot and we're going to discuss incontinence and male stress urinary incontinence in particular, and some of the things that we can learn about it and ways we can treat it. So what is male stress urinary incontinence and how common is it? So male stress urinary incontinence is essentially where a man loses his ability to maintain enough pressure to keep urine within the bladder, and that can result in leakage either with activity, laughing, anything that really increases the abdominal pressure. It can be common, particularly in certain patient populations, such as those who've had some kind of prostate surgery. And nearly 1 in 10 men have urinary incontinence, with rates rising over the 60 years old. So the urinary process starts with the bladder. The bladder will squeeze and the urine will then go into the prostate, where you have a urethral sphincter underneath that kind of maintains the urine and keeps it from leaking, which will then exit out through the urethra when you urinate. So again, we talk about what increases risk with stress urinary incontinence. And I talked a little bit about prostate cancer surgery. So men who have had prostate cancer surgery, up to 50% will report some leakage immediately following surgery, with about 9 to 16% will have incontinence 1 year after treatment. So it can kind of change over time. Besides prostate cancer surgery, the stress urinary incontinence can be results of neurologic disorders, enlarged prostate surgery, so not for cancer, but had prostate surgery for other reasons. Had radiation potentially for cancer, or had a trauma to their pelvis that kind of disrupted the nerves and those structures that help us urinate and hold our urine. And this is another area that can severely affect quality of life, along with erectile dysfunction. So studies have shown that people suffering from stress urinary incontinence can suffer from more depression, can be psychologically more distressed, emotionally disturbed, or feel socially isolated. It's an issue that a lot of men may struggle with, but don't have anyone to talk to about it, or kind of quietly suffer through it without realizing that there might be options to help. So let's talk about its relationship with prostate cancer treatment and why it happens with prostate cancer surgery, for example. So prostate cancer surgery, or removal of the prostate, is pretty common. Approximately 70,000 radical prostatectomies are performed each year, with again 9 to 16% having persistent incontinence or leakage of urine 1 year after treatment. A big reason for why this is we remove the prostate, and when that occurs, there can be some injury or compromise of the sphincter, which I talked about, that holds the urine and keeps it from leaking. So you're you're essentially removing a large area that helps keep your urine in your bladder, and then reattaching it. So there's going to be naturally less support after surgery. So some short-term options include behavioral modifications. So telling a patient, hey, maybe don't drink too many fluids, planning restroom breaks to try to prevent them from, potentially leaking in between the times they urinate. Some non-invasive interventions like pelvic floor physical therapy to help strengthen those other pelvic muscles to keep the urine within the bladder and prevent it from leaking. Kegel exercises, which work similarly. A method called biofeedback, and then there's other things like pads, diapers, catheters, or penile clamps. So we're going to talk about the male sling. So one option, surgical option to help treat incontinence, is the male sling. So the male sling is another device. It's really not a device. It's kind of a mesh that we place that's undetectable. It's within the body. In men with mild to moderate, so within a certain severity of stress urinary incontinence, it can have quite high success rates. The patients that are the right patients and undergo that procedure are typically, continent, meaning they no longer leak immediately following the procedure. It operates on its own to restore continence, and 92% of patients who have undergone it said that they would undergo the procedure again. So how it works is it acts like a hammock. So once you remove the prostate and the sphincter that typically supports the tube, the urethra that you urinate out of, the sling that we place will kind of function the same way, or kind of hold it up and kind of give it that support it needs to reposition and support it, and therefore restore bladder control. Talking about the artificial urinary sphincter, this is another surgery that is done. So, again, I talked about the sling, and there might be specific types of patients that might fit that bill or be good candidates, but patients who may not be good candidates for the sling, say they have a little bit worse leakage, that the sling may not, keep them dry. Then we look at the artificial urinary sphincter. This is considered the gold standard treatment, particularly for post-prostatectomy incontinence. In terms of quality of life and how it can really positively impact patients, it's provided proven discrete bladder control. Another device that's all internal and undetectable to others will mimic a healthy sphincter. And most men with a weakened sphincter muscles will achieve continence with this. And this is how this works. So the implant itself, again, compromises several components. You have a reservoir, again, like you do the penile implant, but this one is smaller, again, placed in the abdomen. You have a small pump in the scrotum, similar to the penile implant. But these then go to an inflatable cuff that we place around the urethra, the tube that you urinate out of. And how it works is you basically activate whether that cuff is inflated or deflated. And if that cuff is inflated, it squeezes the tube, your urethra, and closes it, and therefore keeps you dry. And when it's time to urinate, you use the pump to then activate it to remove the fluid back into the reservoir, therefore opening the urethra, the tube that you pee out of, and you urinate. So you're basically have full control over when you want to urinate. And we have another video demonstration here kind of illustrating that. So as you can see here, again, all the components are internal. When the man squeezes the bottom of the pump, this will move the fluid from the cuff to the reservoir, therefore deflating it and opening the urethra and allowing you to urinate. And then it will cycle and reinflate to close the urethra and stop urine from flowing to keep you dry and prevent leakage. Again, this is also considered an outpatient procedure. There will be some couple small incisions, one on the groin and one down in behind the scrotum on the perineum, both about 2 to 4 centimeters. Again, in terms of getting back recovery, it's usually a few days to return to non-strenuous activities. I don't want patients heavy lifting or that type of thing for a while. And then again, this is another one where we want things to heal and wait about 4 to 6 weeks before using the implant to ensure full healing. And in terms of the statistics, again, it's pretty good in terms of patient satisfaction. 94.6% of patients are claimed to be satisfied with their device. Around 90% of patients are satisfied with their device long-term, meaning 10 plus years. 90% of patients would have the surgery again, and 94% of patients would recommend the device to a friend or family member. Again, when looking at cost and coverage, insurance coverage for erectile dysfunction will vary. Incontinence treatment is commonly covered by insurance. There's usually less pushback compared to penile implants, and coverage may be available under Medicare or Medicare Advantage. And again, this is another one where you want to talk to your specialist and see if you can find solutions if it's something that you really want to undergo and move forward with. So again, the benefits of stress urinary incontinence products: ability to achieve incontinence, ability to urinate when you want to. It's all concealed within the body, is undetectable to anybody else. High satisfaction rates amongst patients, and helping to restore, that kind of normal lifestyle and renew confidence. So again, talking about how the quality of life effects. Again, talking about risks. So similar to any implants, will have similar risks, mainly being device failure. For the sling, you worry about making that sling too tight, where some patients might not be able to urinate at all, resulting in urinary retention. Some might have some post-operative pain, irritation at the wound site, or have a foreign body response. For the sphincter, side effects might include, again, device malfunction or failure that would require us to remove and replace it with a new device. Erosion of the urethra. So sometimes that cuff can be too tight and can kind of squeeze, and the implant can erode into the urethra tube that you urinate out of, in which case we would typically remove the device and allow things to heal. Another one where you can result in urinary retention and not be able to pee, or infection, pain, and soreness. So to summarize, in terms of stress urinary incontinence, again, we know that this is a common side effect of prostate cancer treatment, that there are a variety of treatment options available. Short-term options can be expensive and uncomfortable, especially when you're looking at quality of life as well. And, sling surgery or artificial urinary sphincter surgery could offer a long-term solution for various patients. And again, this is my information here. Again, for any of those who are interested, please look me up, and I'd love to meet you in person.